Okay, wonderful. We see you very well, so welcome to the session. We've got a nice audience this morning. We're excited to hear what you have. So Dr. Rao, Chandra Sharma, so welcome. Please introduce the case and your team, and then we can get moving.
Good morning from Jaipur, and thank you, India Live, for having us in this session. Let's go to the case presentation. So before we start this case, let me introduce my team. That's me. My name is Ravinder. He is Dr. Kailash, Dr. Govind, and Dr. Vikram. He's our intervention structural fellow. He's going to spend 1 year with us learning all structural cases. And here's Dr. Prashant Vashne. He's a cardiac anesthetist, and he's part of all our TAVR and mitra clip, specializes in DE for mitra clip, and our whole technician team as well. So without wasting any further time, let me go ahead and introduce the case. So we are going to show a TAVR in a nonagenarian scenario. Next slide. That's where we work. Next slide. That's our team. Next slide. So this is a 93-year-old lady. She's a freedom fighter. Her husband was also actively involved in Indian freedom movement. She's presently independent, does all her activities by herself, participates in all social functions. She was having class 3 to class 3 dyspnea for past 4 years, severe aortic stenosis, mild AR, EF of 50% in 2020. She was doing well with medicines, and then she started having recurrent hospitalizations 5 times in last 1 year, hypertension, CKD, anemia. Her body surface area is 1.14 meters square. Her last admission was in Feb 2023 with heart failure, and patient was not improving despite best medical ICU care. So we decided the echo at that time showed peak gradient of 95, mean gradient of 61, EF of around 30-35%. Next slide. This was the EKG, normal sinus rhythm, some STD changes. Next slide. So the patient was not improving, and we were just debating what should we do for this patient. We did a balloon aortic valvuloplasty with an 18 mm ZMED balloon, and you can see those gradients, more than 50% reduction. Patient did extremely well, got discharged from ICU after 2 days, and was back to her normal life. And that's when we decided to do a transcatheter aortic valve replacement for her. Next one. So patient improved, was willing for TAVR, heart team meeting, and there's no doubt, 90 nonagenarian is always TAVR. TF TAVR, now plan was 1 ProGlide with provisional ProGlide angioseal. Next slide. Now this is the CT scan. The area derived diameter is 20. The area of the annulus is around 320 millimeters square. The left coronary height is 7 millimeter. The right coronary height is 12 millimeter. This left sinus of Valsalva is around 24. The right sinus of Valsalva is again around 22. Can we have the slides, please? And the non-sinus of Valsalva is 24. Next slide. And you can see there's not much of calcium in the annulus, not much of calcium in LVOT, a tricuspid aortic valve. Next slide. Calcification in the STJ, ascending aorta, leaflets, extending all the way till the base of the leaflets. Next slide. Next slide. Oh, so go back to the previous slide, and here you can see the length of the membrane septum. It is 8 millimeter. And this patient already has a narrow QRS complex, and we measure membrane septum for all our patients, and it just helps us to kind of educate the patient as well. Now let's say the membrane septum is 2 mm. I'm just going to tell the patient that you are at a high chance of pacemaker. My depth would still be around 3 to 4 mm. Next slide. Femoral vessel size is good enough. Both the sizes more than 5 millimeter. Next slide. In this calcification, you can see the calcium porcelain aorta and calcium all in the descending thoracic as well as in the pelvic vessels. Next one. Femoral bifurcation, tortuous femoral vessels. Next one. So the summary of the CT scan: aortic annulus area is 320 millimeter square, LVOT area is 332 millimeter square. 20 mm octacore at the level of annulus is minus 1.8%, at the level of LVOT is minus 5.4%. Now intermediate size octacore 21.5 at the level of annulus is 13.5%, at the level of LVOT is 9.4%. Now let's assess the risk of coronary occlusion in this patient. We're going to do a coronary alignment, commercial alignment. The left coronary height is 7 millimeter. The sinus of Valsalva diameter, the left sinus of Valsalva is 24. The right is 23, and the non is 24.6. For pacemaker, we have a good membrane septum height, which is 8.6 mm. as well as narrow QRS EKG. Next one. So this is how the valve is crimped in order to do a commercial alignment. This is a clock which is there on the crimping tool. The RCC is crimped, and majority of time the valve, when it is deployed, is going to have a commercial alignment. Next one. Next one. Next one. This is our small experience of Jaipur. Next slide. We have analyzed our 200 cases, compared MyValve, Evolute, and Sapien. Equivalent results in all 3 cases. Next one. So next one. So the pacemaker rate is equal in all 3 valves. The 30-day mortality is similar in all 3 valves. In-hospital mortality also similar in all 3 valves. Next one. So our plan for this case, she's a 93-year-old lady, a transfemoral TAVR, 1 ProGlide, conscious sedation, coronary protection, cerebral protection, coronary alignment. Now the debate is 20 mm versus a 21.5 mm octacore. So, and then a coronary protection with a guide versus no coronary protection with a guide. So with that, we're going to show our case here. We have a 6 French, can we see here? 6 French artery on the left side, another 6 French artery on the left side. We have a vein with a temporary pacemaker in, and we're going to show an ultrasound-guided femoral access, 1 ProGlide, and this is where we are. Questions? Unfreeze. And here you can see the ultrasound. Can we have the ultrasound on the screen, please?
Ravindra. Can you hear me, Ravindra?
Good morning, sir. How are you? I can
Very-
hear you very well. Can we have ultrasound on the screen, please?
Very well. I presume that the coronary anatomy was okay.
So for the audience, the octa-core is, of course, a domestic design. It's just 2 rows of cell.
Okay, so we did an ultrasound guide here. Can we see down, please?
With a minimal shortening.
Okay, so this is a
by
micropuncture.
implantation.
Come out.
So minimal shortening of 19 to 21%. And obviously the experience with the commercial alignment in this country is quite substantial. As a matter of fact,
Come
there
out.
is a publication a paper submit about 35
dilator.
cases with multi-slide CT scan pre and post. And it's, with the complexity of the case in India with a lot of
Blade.
bicuspid valve, it's a very useful technique that was shortly alluded to with the outside the patient taking into consideration the anatomy, be able to align the commissure. Yeah. I'm very impressed by the
Thank you,
work
Professor
out of
Arias, for
this,
highlighting that.
patient. It's very well done. It's, yeah. And also
So we have taken 1 ProGlide. We're going to deploy a 1 ProGlide on the right side.
Looks like the frame height is 17 millimeters from what I can tell.
yeah,
Yeah.
yeah, yeah.
Can I have the mosquito, please? So we have switched to totally just one closure device, and we presented our comparison of 2 ProGlide versus 1 ProGlide and provisional second device at London Valves as well. What we have seen is the minor vascular complication is more with 1 ProGlide, like some oozing, hematoma, but the major vascular complication rate, vascular occlusion, requirement of a stent and requirement of a surgery is not there with 1 ProGlide. So here's a 9 French sheet. Can you hear the stiff wire? Okay. You can also play the angiogram. Yeah, let's see what all we have done here. So, okay, so that's the aortogram, and you can see there's significant aortic regurgitation as well because we did a BAV in this patient with an 18 balloon. Next one. This is the first one. So we did a arch angiogram, and next one. And because of heavy calcification, a nonagenarian 93-year-old, we decided to do a cerebral protection. Here's a sentinel device. Next one. The proximal being deployed. Next. And here's the distal one which is deployed. And we just advance the pigtail to make sure it is not coming in the way. So the 9-French sheath is removed. And now we'll go ahead and use a Python sheath, which is an expandable sheath. So, Dr. A.B. Mehta and Professor Serious, the question which I wanted to discuss is 20 versus 21.5. We have decided to use a 20 valve because, again, looking at the age, the body surface area is just 1.14. Number one, and number two, coronary protection versus no coronary protection with a guide and a stent.
It's interesting that in Europe, I mean, a lot of intermediate size are used, especially in the Netherlands. You know, there are big guys, so we use a lot of 30.5 and 32 millimeter valve. I mean, because we need that, so it's a major advantage. And the Python is a remarkable sheet, you know, 14 French for all the valve, including the 32. So that's reaching the market very powerfully.
How much force does it take to get the valve through there?
Look at the valve.
Sorry?
Does it take a lot of force to get the valve through there, or no?
No, not especially. I mean, you know, this week we did a few aortic regurgitation, pure aortic regurgitation with the 32. So you compensate for the anchoring without calcium. I mean, one case had something like 148 millimeter square of calcium. We compensate by the diameter of the valve. I mean, that's the way to anchor in pure aortic regurgitation. Here also there's not so much calcium, and there is a substantial aortic regurgitation.
So would you protect the left main a priori in this case? I would be very tempted just to put a guider and have it. I don't see the downside of it.
Yeah, the point is that with the octa-core you have only 2 rows.
I understand.
And one row is completely open, and the other is with the external and internal skirt. So the access to the coronary artery is also quite good. Yeah.
I agree. The only challenge which we see in protecting the coronary with a guide is so much of calcium in the STJ and as well as the left main. If this was, if we were using a 21.5, we would have 100% protect the coronaries. But as of now, we are planning to use a 20 valve.
Okay.
And the sinus of Valsalva left side is 24. We have decided to have our guide ready, a wire ready, and not put the guide, engage the guide up front in this very cramped anatomy. You see the STJ, the whole ascending aorta, it's heavily calcified. Okay, so here's our pigtail. Okay, let's have our pressures, please. Okay. Let's have our Safari extra small wire.
I mean, the fact that they have changed for the octa-core from hexagon and octagon is quite amazing. I mean, and this technique of the interlace struts it's phenomenal. I mean, it's really very ingenious from the people in India to have created very quickly something which was never done before. Yeah. I predict that it will be a
Let's have
very
the valve, please.
successful device worldwide. Yeah.
Logically sure.
The other thing I don't know we want to share with all the audience is what we do is we would be wearing 2 gloves before the procedure, and when we take the valve, we would take our outer gloves. And that is because if you look at the explant Tavi study, one of the important indications for patients who are undergoing surgery after Tavi procedure was infective endocarditis. I don't know how much this will help, but this is what we practice at our center. Just before the valve, change the gloves, and something like how a surgeon would practice. So this is the octacore.
What
can you
antibiotics
see
do you
down?
give for prophylaxis?
So majority of our cases just get ceftriaxone. So you can see the sheath tip and the wire both in the same view, and here's the octacore valve which comes. Let's go to the LAO, please. Okay, just flex a little bit so that we make sure it's not interacting with the cerebral protection sentinel device. Show me up. Okay.
Also, for the operator going from the my valve to these octacore, it's much more simple in terms of marker.
save.
I mean, and
Let's go to
basically
the-
you are
let's go
targeting
to the,
for
deployment angle.
80-20, even 85-15. I'll see what the operator is doing in this case.
Really tracks up nicely, doesn't it?
So push your
Yeah.
wire.
Beautiful.
Yeah, let's just keep it there. Okay, that's good.
You see it.
So yes, Professor Seris already highlighted how to position this valve, but the good thing in this valve is there's not much significant foreshortening which you will appreciate fluoroscopically. So you can see those marker, you can see a wide marker there. That's what we would like to place at the level of annulus. Okay, let's have an angiogram, please. Inject.
Yeah.
The other thing is before you deploy, you make sure, these are standard steps, make sure it's not on the inner curve, it's more in the center or on the outer curve. And if it is required, you might go a little push-pull thing. But I think this looks like a good position for us. Okay, so let's go ahead. Pace at 180.
So the initial positioning is very simple.
going up.
I mean, you know, the
Yeah,
question
start
is
going
the
Fully deploy.
operator in this country knows
1001,
very well how to
1002,
do the
1003,
push-pull a little
deflate.
bit.
Stop pacing, fluorosave.
Now's the moment of truth.
Yeah.
Yeah, we're going to go ahead and take a picture. I'm just more concerned about the coronary. Let's have a picture. And you can see the depth with the jailed pigtail. Okay, let's go ahead. Wait a minute. Show me the pigtail above. Okay. Yeah. Okay. Ready for injection? Inject. Good. So coronary is flowing. Okay. Let's remove this thing. So sometimes, protecting the coronary looks easy, but in these calcified lesions, we have had problems in the past where we protected the coronary. At the end of the day, there was a dissection in the mid-LAD, proximal LAD, just by placing the stents in these calcified blockages. So I think if the, okay, let's go ahead.
But
Okay, just
you
look-
could see you have the
Let's-
upper
let's-
cell, which is quite open. So the access to the
Yes.
main stem is quite easy. You can see the three
Let's
posts.
put a pigtail.
Three posts you could see on the metal.
Yeah.
It's quite far away from the main stem. Yeah.
And I would like to also draw your attention to the EKG, still same narrow QRS, and then we'll discuss the foreshortening also when we started with the valve deployment. Apparently to the eyes, it just ends where you want it to end. Okay, let's have this.
Yeah.
No, it looks very nice. You
let's
can
try
see
it.
the native leaflet and the cusp was pushed up as well. So still would be nice to see the ostium of the left main, make sure it is
Let's have
not,
one picture. Okay, let's go LAO cranial.
Very nice.
So in the lower row of cell, you have the external and the internal skirt, but the upper row is completely free, of course.
More, Elio.
You could see,
Yeah, good.
you
Looks
can
like,
see a
Go
little
slightly
bit the
cranial. Good.
interlace struts of the octagon.
by the way, it seems like an ideal valve.
So, we'll take a
Right?
Yeah. Absolutely no grade.
we'll take a picture here, and another point for the audience is, when you want to make sure that the left main is free or away from the valve frame, go to the iliocranial
Yeah.
and then take a picture. So this is the iliocranial, remove parallax in the valve, and let's go ahead and inject, please.
Looks good. Looks very
So
good.
left main is
Even
nicely
with a
flowing,
big
and you can
tail
see the
into the valve, I mean, zero regurgitation, good access to
We-
the
we-
to the main stem.
and then we're going to
I'll
remove
make
this
a
thing, and we'll take
statement.
one
I
more
think
picture
that
just to
India can be very, very
10 ml.
proud to have created that technology. There's no doubt about that. Yeah,
Very impressive.
very.
just one thing which I want to share, Professor Serious, because everybody is there. We did the first in man case 6 years ago. That patient is still there with single digit gradients.
Yeah.
Let's go ahead, inject.
No, I
So
think
we
it
see
will
no
be-
change in
it will
ECG,
be
no paravalvular
worldwide a
leak,
very successful
and good
story.
coronary
I mean,
access.
whatever I have seen, and this week, I mean, we did a case in Mumbai, in Wapi, and so, I mean, all the cases were spectacular, aortic regurgitation, and so 32, I mean, every time it's end up with perfect results, so and you have seen the speed of
We have some time. We're
Very
going to go ahead and close the
just
groin
made
as well.
one positioning, the marker at the bottom of the pigtail, that's it. No manipulation. If you look at the skill of the previous case, where you
Show me
have to
above.
do the pacing and the multiple injection, and
Show me
this
above.
is simple.
Less than
This
10
is-
minutes. Less
yeah,
than 10 minutes.
Go ahead,
Yeah.
remove this.
I was watching the time. It was literally less than 10 minutes.
Absolutely.
We need this technology in
But
the U.S.
it is a
Thank you. We
wonderful
wanted to have some time for
team,
discussion.
wonderful team. They made
Yeah.
the point.
Made it look easy.
We still have 12 minutes and 38 seconds.
Maybe you can do another one.
So we're gonna the groin closure, and we'll remove the sentinel as well, and we'll have some discussion.
Let's put Raj Makar on the
Yeah.
spot and go to the microphone and give your impression about this case. Yeah,
Microphone on, please. Microphone on.
take care of the microphone because we want to hear what he's going to say. Otherwise, you come here. Come here.
Good morning, Raj.
Good morning, Ravinder. Congratulations. I think you did this case beautifully, in a very slick fashion. And I also looked at the results of your center, and I think they're as good as any excellent center actually, anywhere in the world. So I have to say
Thank you
congratulations.
so much. Thank you.
On
Thank
building a great program. And I think I was just talking to my associates as you were, we use a lot of balloon expandable valve, and so, balloon expandable valves we find are simpler compared to a lot of times, using the self-expanding valves. But I have to say I was very impressed by the fact that you didn't have to assemble the valve. It's already pre-assembled. It was easy for you to track it. And I think the deployment was very precise. So I think as you mentioned, there was no foreshortening. That's exactly what we actually saw. So I think I have to agree that I'm actually quite impressed, by this technology. So I think it's terrific.
So that's a very important statement coming from a great expert. And all the data on bicuspid valve is coming from Raj Makar. And in this country, you can have up to 30% of bicuspid valve. I saw a case of single leaflet at the age of 42. I was really nervous about the case. Result was impeccable. Single leaflet at the age of 42
safe.
with a huge aorta.
Yeah.
And you could
I think it's important to collect some durability data right? So I think there are lots of patients that were done. Ravinder talked about the first patient done 6 years ago. So I think that will give comfort and confidence because we know about the durability of Evolut and we know about the durability of Sapien valves. So I think it is critical to accumulate data about the durability of this valve. And I think that is what will make a difference in adoption worldwide. You know what I'm saying? So I think that would be helpful.
I agree. That's
So
the important question. I think that's how, because as we are moving to the young age, we need to have the durability data on these TAVI valves. So we removed the Sentinel device, which you could see, and Sentinel, it's not an all-comers use for us. We would use it only in patients who are high risk for development of a stroke. We use just one ProGlide. We'll show a DSA of the groin picture. Ready? DSA, please.
check again.
Inject. Some oozing there, we're going to hold some pressure. And the reason is, just one ProGlide, if there's a lot of pinching, we would avoid a second device. We'd just hold manual pressure for 5-10 minutes. But if there is no stenosis and if there's a pulse style flow, we would go ahead and use a second device as an ad hoc. So this is where we are now.
Well,
4 more minutes to go.
Congratulations, really expertly done demonstration.
Yeah, I mean, superb work, good technology, and very impressive case. We are in 2/3 of our trial called Landmark, which is the My valve versus the Medtronic family and the Edwards family. I think we will be finished in December and maybe able to present that early in 2024. And we hope to have at the end of the trial, we hope to have the octa-core in the trial, because in this protocol you are allowed to move with the family Edwards, the family Medtronic, and also the family My valve. And it's really in Europe the person who has the larger experience is Ignacio Amat. I think it's really doing well. Yeah, Raj. Give the microphone again, yeah.
So on.
Yeah, Ravinder, I wanted to ask you a question.
We would like to, yes.
The fact that
Yes,
there's just 2 rows and these are actually large cells, do you see it behave differently? In very heavily calcified valves, one would make the argument that having smaller cells at the bottom, would that actually give you more radial strength, less radial? So is there any observations that you have made, or is there any data on that? Comparing this octa-core versus the previous generation My valve.
No. So, so have I used a lot of octa-cores and heavily calcified valves? Not yet. We are just gaining our experience. But what all valves we have done regarding the radial strength, the expansion, it is almost similar. The only advantage is the deployment is more predictable compared to the first generation valve. So as you saw in this case, it's just you have to train your eyes that to begin, when you start deployment, you feel it is very shallow. It might just pop out. But it's just, as you saw, it just remains where it is. So to answer your question, I think I haven't seen any difference, but I think we have to wait for more and more cases to do.
From an engineering point of view, the fact that you
Yes.
merge 2 octagon together with these interlaced struts make the columnar strength quite good. I mean, I don't remember exactly the value from an engineering point of view, but in Newton per millimeter, it's very strong. So
Okay.
technically speaking, there is more strength and radial force. I don't know if it's going to be translated in a clinical case, but I mean the large majority that I have seen so far is direct implantation, no pre-dilatation, in very calcified valves. So I think it's okay. What do you think? I mean,
Yes, I mean we haven't seen any. So the way to I would like to answer this way: we haven't seen any valve which recoils once we have deployed the valve.
I think that the
Even
other
in a
day,
calcified anatomy.
reviewing the 125 case, I saw only 9% of post dilatation. Yeah, and it's basically not because anything like recoil and so, just to increase a little bit the diameter of the valve because there was a small degree of regurgitation. No, I think it's quite impressive. Yeah. Okay, any question from the
Before you
audience?
sign off, thank you
I
very much
think,
from our team.
it's
Ravindra.
your domestic technology, so you should
Yes, sir.
ask question about your domestic technology.
Patrick, I want to ask an offbeat question. Ravindra, did your patient participate in 1942 Quit India movement or not?
She did, her husband.
You said
That's why he
that
didn't
you
die
said
for
that
her.
she's a
so
freedom
active.
fighter, and she's 93.
Yes,
so it
she
would be
is.
interesting to have first-hand
Yes.
experience from what she has to say.
We chatted, I don't know, I'll record a video and if you're interested, we'll share with her. She is mentally so sound. Her every word she speaks is so clear. And she does not allow anybody to touch her when she's getting out of her bed and she's walking and going to the toilet, except for that 1 month of hospitalization where she was really sick.
I know, I think it's beautifully done, Ravindra. Extraordinary
Thank you, sir.
skill. Lovely.
You know, what I really appreciate is the way you approach the patient, because that individual went 5 times in the coronary care unit of the ICU because of heart failure. Then they did a balloon valvuloplasty as a bridge, saw the improvement, and finally at the age of 93 decide to put a valve. That's perfect clinical approach. On top of a good technology and on top of a perfect team working together. So it's a perfect example of what should be done in the field of TAVR.
Absolutely.
Yeah. Okay.
Thank you.
I think we can get an early start with the next case then, huh?